You are really warmly welcome to this second session in our growth hormone deficiency series on metal. My name is Phil McElnay. I am a physician and passionate educator here on the
You are really warmly welcome to
metal
the
team.
second session in our growth hormone deficiency series on metal. My name is
We are really honored to have you join us today. You are really warmly welcome from wherever you are joining, and we hope that you find this super useful, super engaging, and really helpful session. We are going to be diving into the diagnosis, management, and evolving therapies with a real focus on diagnosis and differentiation of growth hormone deficiency this evening. But before we begin, it's really important that we share with you our disclosures. So I'm just going to bring those up on the screen just now, and they're there if you would find that helpful. The learning objectives for today are as follows. What we hope that you'll be able to leave us with today is being able to evaluate patients with suspected growth hormone deficiency by integrating clinical presentation, laboratory findings, and genetic testing, differentiate growth hormone deficiency from other conditions with similar symptoms to ensure accurate and timely diagnosis in both pediatric and adult patients, utilize appropriate diagnostic tests and interpret the results in the context of each patient's clinical profile, collaborate with specialists when needed to confirm the diagnosis and streamline the referral process for comprehensive care, and to select appropriate candidates for transitioning from daily growth hormone therapy to long-acting growth hormone based on clinical criteria and patient needs. And if this is your first time joining us, you might not know, but we like to do a little poll just before we begin our education. So I'm going to bring our poll right up on the screen just now. And what I'd love to understand is just how confident you are in the topics that we're going to be covering today. And the first poll is this. Before this education, how confident are you in your ability to accurately evaluate and differentiate growth hormone deficiency from other conditions with similar symptoms using clinical presentation, laboratory findings, and genetic testing? 1, not confident at all, right up to 5, very confident. If you can just give us an answer in the poll, that would be super. And if you're just joining us, you're really welcome. We're just doing a couple of polls just to see where you're at in your education journey on this topic right now. And if you could give us an answer in that poll, that would be great. And I'll give you a few seconds just to do that. And then we've got one little case that I'd love to get your thoughts on before we dive into the education. And guess what? It's going to be on the topic that we're going to be covering this evening. And the case is this. A 4-year-old boy presents with short stature, a high-pitched voice, and micropenis. Laboratory tests reveal low IGF-1 and IGF BP3 levels. Growth hormone stimulation tests showed a peak growth hormone level of 0.6 nanograms per milliliter. What is the most appropriate next step? Is it A, initiate nutritional counseling and reassess growth in 6 months? Is it B, begin daily growth hormone therapy? Is it C, perform a brain MRI? Or is it D, reassess growth hormone deficiency at puberty? If you can let us know what you think the answer is, that would be great. And if you missed the first poll, you can still scroll up in the chat on Metal, and you can give us an answer on that one as well if you're just joining. And you can also give us an answer on the case as well at the same time. Okay, super. Thanks, everyone. I really appreciate you sharing your thoughts. We're not going to tell you the answer to the case just right yet, but I know that by the end of the session, you will know what the answer is. So I hope that you are able to pick that answer out from the session, and I hope that you find this a really helpful session. I am really pleased to introduce our speaker this evening, who is Professor Sasigarn Bowden, and she is a pediatric endocrinologist at the Nationwide Children's Hospital. She's also the professor of pediatrics and pediatric endocrinology at the Ohio State University College of Medicine, and she is going to be talking to us tonight about growth hormone deficiency, diagnosis, management, and evolving therapies. So without any further ado, I'm really happy to hand over to Professor Bowden, Prof. Bowden.
It's my pleasure to be here today to speak with you about growth hormone deficiency. I will focus on diagnosis and management and also discuss the evolving therapies. And here's my disclosure. And as you have seen that this session learning objectives are on growth hormone deficiency. And the outline of my talk includes clinical evaluation of growth disorders, and we'll use 2 cases to discuss how we work through the diagnosis. And we'll also discuss treatment of growth hormone deficiency, daily versus once weekly options. So here the definition of short stature is defined as a height below the 3rd percentile or more than 2 standard deviations below the mean. And a significant drop in height percentile can also be concerning, even if the child remains above the 3rd percentile. So looking at this growth chart, we see a patient whose height initially followed the 50th percentile, but gradually declined to the 25th percentile. So the downward shift suggests a potential growth problem that warrants further evaluation. And if we look at the height velocity chart in this same patient, we notice that it falls below the 5th percentile, and that indicates impaired growth, which could be due to an underlying medical problems that we need to address. So monitoring growth velocity is crucial as it provides an early indicator of abnormal growth before a significant change in height percentile becomes apparent. So sometimes, we have to look at growth records to know that there's a problem. So key informations in assessment of short stature. Growth is one of the most sensitive indicators of a child's overall health. Deviations from the normal range, both in height and in the rate of growth, may signal an underlying medical condition that requires further evaluation. There are several factors influence growth, including genetics, nutrition, psychosocial environment, and systemic diseases. So one of the first steps in assessing short stature is to determine a child's genetic height potential. And that's done by using midparental height. And, we have to ask father's height, mother's height. If a child is a boy, then we need to convert mom's height to male height by adding 5 inches or 13 centimeter to mom's height, and then add to dad's height and divide by 2 to get the average midparental height. For girls, we have to adjust dad's height to female's height by subtracting 13 centimeter or 5 inches, and average with mother's height, divide by 2. And when we need to ask about family history, growth and pubertal history, because, timing of puberty plays an important role in growth. And we need to look at the child's pubertal status as well, because sometimes, when we see an adolescent with no growth in the past couple years, and then turns out, the child developed early puberty and has finished growth. So that's something we need to, do thorough examination and, look at the pubertal status. And getting growth records is also important, as mentioned earlier, that we have to look at the trend of growth, coming from higher percentile and drop to lower percentile, that can be concerning as well. And we also need to make sure that we get accurate height and weight measurements, because this can cause interpretation errors if we don't have accurate height measurement. So in young children less than 2, we do supine length, and older than 3, we always do standing height using stadiometer. So the gray zone is the 2 to 3 years. Sometimes the child might not want to stand up, or sometimes we get supine length, and so we have to pay attention to this, because I found that it's a common pitfall in getting correct height measurement. So so we can see here there are 2 types of growth chart: birth to 36 months, which is for supine length, and the growth chart 2 to 20 years is for standing height. So if we have a child who is about like 2-year-old and we get standing height, but if we plot on the 0 birth to 36 months growth chart, we need to convert standing height to supine length by adding 0.7 centimeter, to get the supine length, because supine length is slightly longer than standing height. So this will provide, accurate plotting, on the correct growth chart. So, and here's also to show you the correct technique that we need to measure for infants, that we need to have heels against footboard, and make sure that the shoulders touching baseboard, the crown of head touching headboard, and make sure that the head position in the Frankfurt plane, which I will explain later. And for correct technique to measure height for older child, it's best to have a second person to help make sure that the child standing against the wall or the board at the back, and the shoulder, knees and ankles, everything touching the board, and then we need to make sure that the head is positioned in the correct plane, and we have this imaginary line that runs from the bottom of the eye socket to the top of the ear canal. So this line needs to be parallel to the floor in order to have the right position of the head, because if head is tilted up or down, that can affect the height measurement. So we need to pay attention to this. So in terms of growth rate, growth velocity, the highest growth rate is in utero, 50 centimeter in 9 months. So that equals to 68 centimeter per year. That's very rapid growth that we see in fetus. And after birth, we also have rapid growth as well, about 25 centimeter per year. And then growth rate will slow down to about 12.5 centimeter per year in the 2nd year, and drop to 8 centimeter per year in the 3rd year. So from throughout childhood, from 4th birthday to pre-adolescent years, the growth rate is about 5 centimeter per year, or we say 2 inches a year. So any growth, if we see a child with growth rate less than 4 centimeter per year, that indicates the need for further evaluation. And once kids get into puberty, they will have a growth spurt. And typically girls start having a growth spurt before boys, and that occurs before menarche. And for boys, the growth spurt occurs in mid to late puberty, about 10 or 3 to 4. And, if we do examination during the peak growth spurt, boys have testicular size about 15 ml. So, the peak, you can see, that is about 2 years later than girls. So we have different phases of childhood growth. The first 2 years of life is influenced by nutrition, and growth hormone starts coming into play from age 2 years, and then during adolescent years we have the combination of growth hormone and puberty hormones or sex steroid that help increase growth. So if we evaluate short stature, we should approach by thinking about what's the causes of short stature. We have quite large number of patients that present for short stature that turn out to be normal variant, familial short stature or constitutional growth delay, and the right side is pathologic causes of short stature, and it's easy to classify by looking at the child to see if the child has proportionate growth or disproportionate growth. If you see disproportionate growth like short arms, short legs, that we need to think about skeletal dysplasia or rickets. If having proportionate growth, then it can be genetic syndromes or any causes due to systemic diseases. So here, we'll provide more details about the causes of short stature, systemic diseases. That can be causes due to congenital heart defects or pulmonary diseases or GI problems. The one that we always need to rule out is Crohn's disease or celiac disease, which can cause malabsorption. And very often, some children with celiac disease, they don't necessarily have GI symptoms. The only manifestation is slow growth or short stature. So that's something we need to always think about and rule out. And renal cause, one of the subtle renal condition is renal tubular acidosis. So we need to always check electrolytes, to make sure that we're not dealing with chronic metabolic acidosis. And kids with chronic renal failure can also, have significant poor growth. And then we have endocrine disorders, which I will show later, what could be the causes of short stature due to endocrine disorders. And we also need to think about Turner syndrome, Noonan syndrome, many genetic syndromes that can present with short stature, Silver-Russell syndrome, that's just one of the many genetic syndromes that can have short stature. So for familial short stature, the key is that, the growth rate is always normal. If we look at the growth records, height is has tracking along the same growth percentile and is consistent with the mid-parental height. So we know this is short stature if we have very good growth records like this. And we got to make sure that there are no systemic or endocrine causes to explain, short stature. And if we do a hand X-ray for bone age assessment, very common, the bone age is same as chronological age. And these children with familial short stature tend to have normal timing of puberty. So, they will go through puberty at a normal time because they have normal bone age. So another one of the normal variant for short stature is constitutional growth delay, or, we call late bloomer. So the growth pattern is that, they have normal birth weight and birth length. And typically, they start to slow down during toddler years between, 6 months to 2 years. And then, height will be slightly below the 5th percentile, but then will continue to follow with normal height velocity after that. But they stay below the 5th percentile for several years. And they tend to have delayed bone age, and that can be delayed by 2 to 3 years. And that results in delayed puberty, because we know puberty begins according to the bone age, not chronological age. So they have delayed puberty, delayed pubertal growth spurt, and that helps them to catch up at the end, because then, with the late timing of puberty onset, they will continue to grow and have a growth spurt later. So they end up having, height consistent with mid-parental height at the end and having normal final adult height. So now let's look at the endocrine causes of short stature. Number one that we need to rule out is hypothyroidism, because it's very easy to treat. And, I have seen many kids, present with short stature that are caused by hypothyroidism. So this is something we need to check and screen. And if we look at the weight, records, if you see rapid weight gain with slow growth, we have to think about corticosteroid excess. Maybe need to rule out Cushing syndrome. And one endocrine cause for short stature is growth hormone deficiency. So, there are many causes of growth hormone deficiency. It can be idiopathic, and that can be seen about 40% of cases of growth hormone deficiency. 20% can be due to organic causes, from genetic, and this can be part of the hypopituitarism, or if they have multiple pituitary hormone deficiency, it can be panhypopituitarism. So that can be caused by defects in growth hormone gene. One of the common gene defect is PROP1 mutation, and can be a form of septo-optic dysplasia, which I will explain later. Congenital malformation of hypothalamic pituitary structure, like whole prosencephaly, that can cause growth hormone deficiency. And then we also have acquired cause, part of the organic cause of growth hormone deficiency due to brain tumor, and that's seen about 35%. So this is why we have to do brain MRI scan when we diagnose any child with growth hormone deficiency. We need to make sure there's no structural abnormalities from tumor, or any infiltrative lesions in the brain. So the common cause would be craniopharyngioma, but sometimes, can be from germinoma or ependymoma. And then acquired cause can be due to the late effects of treatment for, different type of malignancy, cranial radiation. And it can also be caused by head trauma as well. So here's a list of lab investigation that we typically do when we assess a child with short stature or poor growth. We want to check complete blood count to make sure that the child doesn't have anemia. We do urinalysis, set rate. This is mainly to screen for Crohn's disease or any systemic inflammatory disease that can result in poor growth. And we do chemistry, looking at electrolytes. And if you suspect bone disorders, you may have to also check calcium phosphorus alkali phosphatase as well, and check thyroid function test. And we do IGF-1, IGF binding protein 3. These are markers for growth hormone. To screen for celiac disease, we do tissue transglutaminase with IgA. And in girls with unexplained short stature, we need to do karyotype to rule out Turner syndrome. And checking bone age X-ray by getting X-ray of the left hand will also help assess skeletal maturation. The diagram on the right is to show you that, because the growth hormone is released in pulsatile pattern, go up and down throughout the day and peaks, at nighttime during the deep stage of sleep. So that's the reason why we do not check random growth hormone, because, the levels tend to be low and it's not helpful. And that's why we do IGF-1, insulin-like growth factor 1, and IGF binding protein 3, as screening tests for growth hormone. So I like to show you the major actions of growth hormone that, it acts in different places in our body. It directly affects on adipose tissue by increased lipolysis. So you have increased free fatty acids. very often children with growth hormone deficiency, they tend to appear a little bit chubby. They have increased body fat, because of lack of growth hormone. And when you have growth hormone, then you have reduced body fat, because of this action of lipolysis. And growth hormone acts on the liver, stimulate gluconeogenesis, and also stimulate production of the growth factors, IGF and IGF binding protein 3s. So that's why we check IGF-1 and IGF binding protein 3. So when we have increased IGF-1 in the circulation, the IGF-1 will stimulate somatic cell growth and also stimulate chondrocyte cells as well to increase linear growth. And another action of growth hormone is on the muscles, that you have increased protein synthesis in the muscle and increased lean body mass. So this is, these are major actions of growth hormone. So I like to start with case discussion. I have 2 cases to present, and they are real cases that I saw, in my career. This is from many years ago, but I just thought he present very classic case of growth hormone deficiency. So he present at the age of 4 years 2 months with growth failure, and that's his growth chart. You can see that he had normal birth weight, normal birth length. Actually his birth weight is 9 pounds 12 ounces and birth length 19.5 inches, which are very typical, very good size as a newborn. And he's healthy, no problems after birth. His mid-parental height is 5'10", which is between 50th to 75th percentile. So you can see that, his length plateau, starting from age 12 months, just having no growth. So when I do physical exam on him, he appears to be a little bit chubby, cherubic face. And when he speaks, he had slightly high-pitched voice. And when I do GU exam, he has slight micropenis. That's just give me a clue to think about, potential cause, of short stature, likely growth hormone deficiency. So I order lab tests, just like what I discussed earlier. Check CBC, set rate, chemistry, and screen for celiac, and they came back normal. Thyroid function test is normal as well. And he had quite low IGF-1 level and also low IGF binding protein 3 as well. So the next step is to do a growth hormone stimulation test. And, we have option to do arginine clonidine or arginine glucagon. We always use 2 agents, to avoid any false positive, false negative results. So, and his growth hormone levels during the test are very low. You can see that the peak is only 1.2. The cutoff of growth hormone levels on the growth hormone stimulation test, can be less than 7 or less than 10. In the US, we use cutoff less than 10. To make a diagnosis of growth hormone deficiency. And this patient, his levels are extremely low. So he had, maybe complete growth hormone deficiency. So the next step that we need to evaluate is to see if he had another pituitary hormone deficiency, aside from growth hormone deficiency. So we already done thyroid function tests. So the next one that we need to assess is adrenal function. And that's done by ACTS stimulation test. And he had normal cortisol response to the test. So, and then we obtained brain MRI scan, and we found that he had pituitary hypoplasia, and that's one of the causes of growth hormone deficiency due to, it's a genetic cause. He's born with pituitary hypoplasia. So then we have to think about, the possibility of having another pituitary hormone deficiency, which is gonadotropin hormones. But, since he's 4 years old, we cannot assess this yet, but having micropenis, might make it possible that he may have growth hormone deficiency and hypogonadotropic hypogonadism. That's possibility, but it can be just isolated growth hormone deficiency as well. That can also result in micropenis in boys. So that's something we have to wait until he's in puberty, then we can, do assessment for gonadal function. So the treatment for this child is to start growth hormone therapy. And, back in those days, we have daily growth hormone option only. So that's what he's on. He was started on growth hormone daily injections. Now we will look at case 2, 11-year-old girl with short stature. And you can see on the growth chart, her height is significantly below the 5th percentile. And per history, she started falling off the growth curve around 5 years of age. And she had no negative past medical history, and she denied any history of headaches, no vision problems, and no nausea, vomiting, constipation, or diarrhea. Her midparental height is about 5'4" or 50th percentile, normal puberty onset in parents. And we did lab investigations, and you can see that she had normal CBC, set rate, electrolytes. Her free T4 was borderline, at the bottom end of normal range. And her IGF-1 is low at 53, and IGF binding protein 3 is low as well. And her bone age is delayed at 7 years, 10 months for her chronological age of 11 years. So this child, I have, I'm, very concerned about her significant short stature with low IGF-1 and IGF binding protein 3. So what I did on her is that, I requested brain MRI scan on the same day that she come in, for brain MRI scan, and also request growth hormone stimulation test done on the same day. Typically we do the stim test first, and then, with positive results for growth hormone deficiency, then we'll do brain MRI scan. But for her, because I have high suspicion for organic cause of short stature, I requested brain MRI to be done on the same day as the stimulation test. And her growth hormone levels on the stimulation test are very low. So likely she has complete growth hormone deficiency, and her cortisol was suboptimal. Back then the cutoff is greater than 18, and her peak was 12.2, which is also low for the new lower cutoff for newer assay. And her sodium is 144. Specific gravity of her urine is a little bit low, 1.005. And here's her brain MRI scan results. It shows mixed cystic and solid cellular and supracellular mass, most likely craniopharyngioma. So we quickly consult neurosurgery, and she had cranial surgery, to remove the tumor, and the pathology result confirmed craniopharyngioma. So after surgery, she developed post-operative diabetes insipidus. So she became she has panhypopituitarism after surgery, with growth hormone deficiency, adrenal insufficiency, hypothyroidism, and DI. And she also has hypogonadotropic hypogonadism as well. So she requires multiple hormone replacement therapy. So this is an example of a case that presents with short stature with no other symptoms at all, and turned out having craniopharyngioma. So it's very important when we assess short stature, because it can be it can be due to very serious medical condition. So I'd like to show you clinical clues for growth hormone deficiency in children. In young infants, they may present with hypoglycemia, that can be present from birth, and in severe cases with growth hormone deficiency. And they may also have cortisol deficiency as well, part of the hypopituitarism. And sometimes they may present with prolonged jaundice, and that could be because of the combination of growth hormone deficiency and hypothyroidism that can result in jaundice in infants. And just like the first case that I presented, that having micropenis in male infants, could be a signal for growth hormone deficiency plus minus gonadotropin hormone deficiency as well. And they may also have midline defects, which I will show in the next slide. And for children, the hallmark of growth hormone deficiency is slow growth. You have a height that is not keeping up with the normal growth chart, and height below the 2 standard deviation below the mean, and height velocity less than 5th percentile. And they tend to have delayed bone age as well as delayed tooth eruption as well. And because of the immature laryngeal structure, they may have a high-pitched voice. So for midline defects, the most common midline defect is septo-optic dysplasia. So they have the triad of absent septum pellucidum or corpus callosum, and they have optic nerve hyperplasia. And then the third one is pituitary hormone deficiency. So all these three may be present, or could be 2 out of 3, that we can call septo-optic dysplasia. And cleft palate can also be, clues for growth hormone deficiency, and that will require, lab workup to look for possible panhypo or hypopituitarism. Single incisor is also one of the clues that we have to think about hypopituitarism or growth hormone deficiency, choanal atresia, or encephalocele, the defect of the skull with protruding brain tissue. And, we know that growth hormone deficiency can be caused by genetic disorders. And, we know that 5 to 30% of children with growth hormone deficiency have first-degree relatives with growth hormone deficiency. So there are many genes that can cause growth hormone deficiency. The common one is the defects in the growth hormone 1 gene or growth hormone releasing hormone receptor gene. And we also have defects on the transcription factor genes, such as PU1F1, PROP1, LHX3. You can see there are multiple genes that can cause growth hormone deficiency, and some of them may also affect other pituitary hormone as well, such as prolactin, TSH, LH, FSH, or prolactin, or the ACTH. So, there are a long lists of different genes that I won't go into detail today, but it's just something to be aware that, many cases of growth hormone deficiency can be due to genetic defects. And there are some uncommon genes such as ALMS1 or IFT172, and some may have, different abnormality as well, like short rib thoracic dysplasia or polydactyly, and could be part of Alström syndrome. So there are many genetic causes of growth hormone deficiency. So back to our case, go back to the case 1 that we diagnosed him with growth hormone deficiency and start him on growth hormone. I'd like to show you the response to growth hormone. And this is within 3 months of treatment. You can see that, his height improved significantly. His head is now touching the bottom of the countertop in, within the 3 months time frame. And so, this is the typical growth response to growth hormone deficiency in children. You can see that, during the first year or first couple years of treatment, they have rapid, robust growth response. The high velocity could be double of the normal growth rate, up to 10, 11 centimeter per year. And, this is the catch-up phase that helped to restore height, back to the normal height. And then subsequent years of treatment, the growth response will be more consistent with normal growth rate for age. So, this is why it's important to, make a diagnosis early so you can have early catch-up growth, and that can help, to have optimal growth outcome, in children with growth hormone deficiency. So back to case 2, who had growth hormone deficiency due to craniopharyngioma. So you can see that, when she presented, she had significant short stature, and then after receiving growth hormone, her growth height increased. But unfortunately, she had recurrence of her craniopharyngioma, and then we have to stop growth hormone. So you can see, from like age 13, her height plateau because we stopped growth hormone briefly during her tumor recurrence, and then she restarted growth hormone again with increased growth. But then, it's plateau again around age 16 or close to 16, and that's because of her second recurrence. And she continued to have increased growth even well into 18, 19 years old, and it's because of her delayed bone age, as long as bone age, with growth plates that are still open, they still can continue to grow. So I like to mention briefly about, cases with tumors, that result in growth hormone deficiency, that we need to know, when to start growth hormone in those children that have malignancy. So we found that growth hormone replacement therapy does not increase the risk of cancer recurrence or second malignancy. And the timing, to start growth hormone in patients with tumor or malignancies, varies depending on several factors like the type of cancers or the treatment course. But recent evidence suggests that earlier initiation may be safe in selected cases, like in childhood onset craniopharyngioma. We found that there's no increased risk of tumor recurrence or progression when growth hormone replacement therapy was initiated 6 months after the last treatments. So, in the past, we used to wait for like a year, but I think now it's been shown that it's safe, to initiate growth hormone 6 months after completing treatment. So for non-functioning pituitary adenoma, that is considered to be safe to start growth hormone, with no risk of tumor progression. And for other cancer survivors, the timing of growth hormone therapy depends on, each case that we need to assess, and it depends on many factors. But the key is that we want to make sure that the tumor or cancer is not active and is well controlled in remission. So for growth hormone therapy, the starting dose is 0.16 to 0.24 milligram per kilo per week, and it's given daily, but sometimes, we can do 6 days a week, give 1 day holiday. And then we titrate the dose, based on IGF-1 response. That, IGF-1 needs to be checked periodically, for safety monitoring. And if you have high IGF-1 while on growth hormone therapy, then we recommend lowering the growth hormone dose, in order to keep IGF-1 in the normal range. And we need to look for any adverse effects of growth hormone. And, within the recommended dose, we found that, the risk of adverse effects are quite low. So, but the potential adverse effects that we can see is intracranial hypertension that present with headaches, persistent headaches, or knee pain, due to slip capital femoral epiphysis, or in some case with underlying scoliosis, we may see progression of scoliosis. And then patient with high BMI, we need to, check to see if they develop glucose intolerance, hyperglycemia, or even diabetes. But, most of the time I found that, it's very low chance, to have impaired glucose tolerance in lean, not overweight child. So, and duration of growth hormone therapy, we treat until they, when epiphysis near close. So, and we can tell, when the growth velocity is less than 2 to 2.5 centimeter per year. Or born age is close to 15 years for girls or 17 years for boys. So I like to mention history of growth hormone therapy, because this has been a success story, how we can, develop growth hormone to help patients with growth hormone deficiency. And you can see, in the historical photo here on the right that, without treatment, the patients stay very short, very small. And, in the past, before 1985, growth hormone was obtained through extraction from cadaver, pituitary gland from cadaver. But now, we have new technology that we have recombinant DNA technology to synthesize growth hormone. So 40 years of progress. We have here that, in the past, we have daily growth hormone injections, but now, we have option of long-acting growth hormone, given once weekly. So I like to show you the timeline of growth hormone treatment development, starting from 1985 that we have first recombinant human growth hormone approved in the US. And then 1996, we have growth hormone approved for adult growth hormone deficiency. And the long-acting growth hormone was in fact, approved back in 1999. But there's some issues with growth hormone formulation, the long-acting growth hormone back then, it caused, quite many side reactions. So it was withdrawn in 2004. So, but then, in other part of the world, we have long-acting growth hormone approved, in 2009, in 2014. But in the US, the first long-acting growth hormone was approved in 2021. And subsequently, we have different formulation of long-acting growth hormone approved in 2023. So why we need to develop long-acting growth hormone, we know that giving daily injections can be difficult, high burden for patients and families, and that can result in poor adherence. And this correlates to the growth outcome. We found that those with low adherence to growth hormone daily injections, they tend to have lower height percentile, correlate with the, the percent of adherence. So I like to show you, different forms of long-acting growth hormone with different technology that we use to prolong the duration of action of growth hormone. The first one is lonapeg somatotropin, and this is done by TransCon technology. TransCon is transient conjugation. So we have the prodrug that is unmodified, it's the same molecule as the daily growth hormone, but it has the carrier, TransCon carrier, which is the polyethylene glycol that is attached to the unmodified growth hormone with the TransCon linker. So this link, this carrier will help keep the growth hormone, slowly released, allowing, prolonged action of growth hormone. So once, given into, administered to the patient, it will be slowly released. And then, the linker, the carrier will be secreted through renal clearance. So, this one is approved in August 2021. And approved for children older than 1 and weight at least 11.5 kilo. And the second one is somapacitan. And this one is done by binding to the endogenous albumin, with the linker that attached to the growth hormone. So the molecule, the size of this growth hormone is slightly larger than the daily growth hormone, being 23 instead of 22 for the daily growth hormone. So this albumin binding prolongs half-life and duration of action. And, this is done, same technology as the other insulin, the long-acting insulin or semaglutide. And the third one is somatogron. The technology is the fusion protein by, binding 3 carboxy terminal peptides, 3 parts bind to the growth hormone, and that can prolong the half-life. So the molecule is large, it's about 41 kilodalton, and this one is approved in the US in June of 2023. So this is the comparison of 3 different types of long-acting growth hormones, with different mechanism. And as you can see in this table, and the dose is different between each 3. We can't just use same dose as, weekly, the daily growth hormone. We have to, make sure that we utilize the right dose, calculation, for patient. And if you look at the growth response, the high velocity for different types of growth hormone, long-acting growth hormone is comparable to daily growth hormone, about 11.2 or 10.1 centimeter per year. So, the growth response is, pretty much identical to daily growth hormone. And if you look at the average IGF-1 level, well, on long-acting growth hormone, the standard deviation is about 0.72, 0.28, 0.65. So, it's very safe, when we look at the IGF-1 level. So, and here's, we compare, how we dose growth hormone for different type of growth hormone, long-acting growth hormone. You can see that the lonapexomatropin, is like using weight brackets, and you give the entire dose, of the cartridge. So it's pretty convenient this way. You just look at the age bracket and then, give the full dose. But, for those older children, bigger size, we have to give 2 injections, in those weight over 60.5 kilo. And for somapacitan, this one, comes in 3 different pen size, similar to the daily growth hormone. So we can adjust based on body weight. And somatogron is similarly, also adjust based on body weight. And this one, the dose is quite high, 0.66 milligram per kilo per week. And that's because of the large molecular size of the growth hormone that binds to the protein. So if we look at the storage, you can see that, lonapexomatropin, is very flexible, to keep in room temperature. It can stay well in room temperature up to 6 months, whereas the other 2 long-acting growth hormone is only 72 hours or 28 days for somatogron. And if you have missed dose, they recommend giving within 2 days of scheduled dose, and keep it at least 5 days apart between doses for lonapexomatropin, or 4 days for somapacitan, or 3 days for somatogron. So this is something, that you have to look at, all the detail of different, how to prescribe growth hormone, the long-acting growth hormone when using different type. So, we also need to do IGF-1, to monitor, to make sure that the dose is given appropriately, not too much or not too low. And, for daily growth hormone, if you look at the graph here, when you give daily growth hormone, the IGF-1 level is stable, any day when you check IGF-1. But when we do once weekly growth hormone, you can see that, there's a peak that goes up, within 2 days of the injection, and then it will come down, get to the lower trough. The trough is like day 6, day 7. So when we check IGF-1, we need to know which day, the lab is done in relation to, the dose, the last dose. And we have ways to calculate the average IGF-1, if we know, the the timing of the lab. So, for Lonapeg, somatropin, they have different correction factor that you can see here. If you check 2.5 days, correction factor is 1.25. If you check day 5, then it will be 0.87. And we have nice table here that we can use, to do the calculation. So for example, if you draw IGF-1 on day 2.5 and the level is 130, then you have to divide by correction factor of 1.25, then average IGF-1 is 104. So similarly, if you check IGF-1 on day 5 and the level is 90, so you divide by 0.87, then you get corrected IGF-1 or average IGF-1 at 103. So this helps, to make sure that, you interpret IGF-1 lab results correctly. And and you can also do calculation for standard deviation as well. And for somapacitan, this one, also have different correction factor that you can do adjustment, and it's only present as SDS, standard deviation number. So you subtract the factor to get the IGF-1 SDS. And for the somatogron, this one also has the correction factor that you subtract from the observed IGF-1 level. So you can see that if you have lab done on day 4.5 or day 5, down to day 7, then the number is negative. And so when you subtract negative number, it's added to the measure IGF-1 level. And this is an example that you can see, IGF-1 is drawn on day 2. And so we need to subtract by 0.7. So, this is the SDS number, and subtract 0.7, then you get 0.63, which is normal. So that will give you, normal IGF-1 SDS. And if you draw on day 6, then you subtract negative 1.4. So that will change to addition. So you get the, the math that is, plus 1.4 here. So, but, we may find that sometimes it's easier just to tell patient to go get lab on day 4 after the injection, then we don't need to do this adjustment. So here's the conclusions of my talk, that, we need to have comprehensive evaluation of patient presenting with short stature. We do stepwise diagnostic approach, including clinical assessment, laboratory tests, growth hormone stimulation testing, and imaging. And growth hormone therapy is safe and effective. We have well-established safety profile, proven long-term efficacy, and the treatment response is typically very robust in the first year, allowing catch-up growth. So early diagnosis and treatment are critical to achieving optimal height and metabolic health. Etiology of growth hormone deficiency is diverse, so it can be congenital, acquired, or idiopathic. And we need to identify underlying cause, to provide, appropriate treatment. And long-acting growth hormone, is a very attractive alternative, attractive option that we may consider. And the growth outcome is very comparable to daily growth hormone. And, this can help reduce injection frequency, and that may improve adherence and quality of life for patients and family. And due to differences in the pharmacokinetics and pharmacodynamics of various growth hormone, the long-acting growth hormone formulations, we need to make those adjustments or monitor, differently, depending on, different type of preparation. So, the choice between daily and long-acting growth hormone should be individualized. We need to consider patient, family situation, adherence potential, their preference, or any other clinical factors, to determine who is the best candidate for long-acting growth hormone or daily growth hormone. And we need to have long-term surveillance, for long-acting growth hormone, because this is quite new. We still need to collect data to ensure that, we have long-term safety data, in each area, metabolic impacts, and also look at cost effectiveness of treatment as well. And now we'll be open for questions.
Prof. Bowden, thank you so much for an incredible educational session. We have covered a lot of ground in a relatively short space of time, and you've done a brilliant job in doing so. So thank you so much, and thank you for joining us for questions.
You're welcome.
We have got a bunch of questions coming from across our channels. We've got questions covering the importance of early diagnosis, the practicalities, differential diagnosis, and a few questions on genetics of growth hormone deficiency as well. We'll maybe work through as many as we can in the short space of time that we have. If you are joining us and you've got some questions, feel free to pop it in the chat, depending on the channel you're on, or pop them onto the chat on Medal, and we'll try to tackle those. Prof. Bowden, I want to kick off with maybe the importance of diagnosis and detection of growth hormone deficiency. So we've got a question about what are the potential long-term consequences in childhood and adulthood of delayed diagnosis of growth hormone deficiency, particularly concerning final height, metabolic health, psychosocial well-being. It's an interesting question.
Yes, so thanks for the question. This is very important to emphasize, the importance of early diagnosis, because, we have some cases that when undiagnosed, especially in infants, where they can develop hypoglycemia. So that's very important metabolic health that, can be missed, and patients suffer because of, untreated growth hormone deficiency plus minus cortisol hormone deficiency. They can have hypoglycemia. So, doing the workup early, try to identify the cause, will be very helpful to help prevent this metabolic complications. So in terms of final height, the delayed cases, delayed diagnosis, the good news that, they have delayed born age, so that helps them to be able to catch up, no matter how delayed, as long as they don't go into puberty. We have some cases that have growth hormone deficiency, but they have intact gonadotropin, and if they get to the age that they develop puberty, so that can affect, a final adult height, because they don't have much time left to have catch-up growth. But, if they have delayed puberty as well, as long as born age growth plates are still open, we still can treat them, because like my case too, she came very short, and, with the treatment interruptions, she's not growing during that time. But because her born age still delay, very much delay with open growth plates, she can grow as long as, her growth plates remain open. So that can get her to grow even into her 20s. And in fact, I follow her long enough to see that she's still growing at, in her 20s, when her born age was only 14. That's give her plenty of time to catch up. And for psychosocial well-being, that's can be hard, on kids who are not having normal height. It can cause psychological distress, especially in boys. And, nowadays, I think, patients get referred to endocrinology early, so, they don't have they don't have to wait too long to, get diagnosed and then start on treatment. But this is very important for general pediatricians or healthcare, primary care providers to, address growth problems and refer to endocrinology. And you can also do initial workup, according to the lab that I showed in my slides.
And I guess let's move on to some of those practicalities, because we've got some questions around some of the topics that you've discussed around how we go about making the diagnosis. So one question is, you've highlighted the importance of accurate growth measurements. In your experience, what are the most common errors in obtaining those measurements in clinical practice? And is there anything we can do to minimize them, especially in busy primary care settings?
Yeah, so, in our endocrinology clinic, we train our nurses, to be very, to follow the strict guidelines in terms of height measurement. The common pitfall, common errors in other clinics, that we encounter frequently is that, some clinics measure height with shoes on, so that can add like another inch. So when you plot height all together from different clinics, you see, the height plots kind of like up and down, zigzag. Some plot is so high, and then when they come to endocrine clinic, it's lower, and that's because, the way they measure, they don't have the patients take shoes off. And then, in toddlers, sometimes it's very difficult to, to have them stand up straight. They can bend their knees, they can, tilt their head, so that can cause errors in height measurements. So in busy primary care setting, I think, that can be challenging, right? Because you need to get patient in and out and do height quickly. So, I think, maybe have another helper, to help keep child standing upright, and that can help, and also don't rely on just one measurement. Maybe have patient come back again, to see height trajectory, because sometimes we have one error in height measurement that show, very low, on a growth chart, but when coming to our clinic, we get correct height measurement, which is on the chart. So the patient has no short stature, doesn't have short stature. So that's also a very common error as well.
We've got an interesting question about when there's a case where there's clinical data that's inconclusive for growth hormone deficiency. What are your preferred next steps if you're not sure based on the clinical data you have, and how do you decide when to proceed with growth hormone stimulation test versus other evaluations? So I guess it's a question around, uncertainty with growth hormone deficiency diagnosis.
Yes. So, if we have someone who has low growth velocity and height, clearly below the third percentile, that's, no, it's very clear that we need to move further, to do growth hormone stimulation test. But we have some that, maybe still at the bottom of the chart, not quite, drop below the chart. But, if we compare to genetic height, mid-parental height, if it's like way below, the genetic curve, that's when we need to make clinical judgment that, this is abnormal for this family. That mid-parental height is higher percentile, but the child is, at the bottom, but not quite like low. So I think, those warrant more diagnostic workup, to growth hormone stimulation test. So I think we need to look at the big picture, not just rely on, one plot, high plot, or, or the strict criteria of short stature, like if you have tall person that now dropping, with no growth, and then drop to 25th percentile, not quite yet below the curve, but that still can be, signs of, abnormal growth, having growth hormone deficiency that, develop later in life. So I think, we have to have all the clinical information, history, growth records, and do initial lab workup, and then we can make decision about when to proceed with more advanced tests.
Follow the diagnostic process, right? That's like what I'm hearing, right? So when it's inconclusive, keep going and do the appropriate investigations. We've got a really interesting question about celiac disease. So you discussed the importance of considering celiac disease in children with short stature. What are the most reliable screening tests for celiac disease in this context, and when should we consider intestinal biopsy for confirmation?
Yeah, so we have very good screening tests for celiac disease, which is tissue transglutaminase. We can also do anti-gliadin antibodies, but for me, I think tissue transglutaminase is very sensitive, and when the titer is high, typically when they have poor growth, their titers tend to be clear cut, it's very high, and and we refer to gastroenterologist, to do biopsy. So I leave that to GI doctor whether or not they want to do biopsy. Typically, they do to get pathology, it's more definitive diagnosis. And so yeah, our role is to screen, if you have elevated results, then, you refer to pediatric gastroenterologist.
And sticking on that same theme of additional tests, we've got some really interesting comments about genetics of growth hormone deficiency. So, given the increasing availability of genetic testing, how has this technology impacted your diagnostic approach to growth hormone deficiency? And in which scenarios do you find genetic testing most beneficial?
Yeah, so, for a long time, in our practice, we don't really, get genetic tests to get, to the root cause of growth hormone deficiency. It's not a common practice to get genetic tests, because it doesn't change our treatment plan, regardless of the causes, in terms of, after we get MRI, we don't see brain tumor, we don't go further to do genetic tests. But since it's available, it can be done, because sometimes, we want to know, what's the gene mutation. But again, it doesn't change management plan. So I think most pediatric endocrinologists we don't often check genetic tests because of this reason, because it doesn't change, our management plan. I think the most important thing is that we need to rule out brain tumor.
And sticking on that same theme, and that might be the same answer, but another question for patients with combined pituitary hormone deficiencies, what is the clinical significance of identifying the specific gene mutation, and does this information guide prognosis and management, particularly considering the risk of other endocrine abnormalities?
Yes, without any genetic test results, we screen for other pituitary hormone deficiency anyway, because we want to identify and treat them accordingly. So, similar to the previous question that, we don't typically order genetic tests, I think it's more for research purposes, to look at, statistics of, different genetic mutations, the different causes. But, because we do endocrine testing and we know what's deficient and what needs to be treated, and I think, that's good enough, to take care of the patients. But, genetic test is just more for research setting, for academic setting that, they do this to understand, what the genetic causes of growth hormone or, multiple pituitary hormone deficiencies. But it doesn't change our, treatment.
Prof. Bowden, you said something during your presentation which really stuck with me, was that you had the privilege of watching someone who you treated as they moved into their 20s, and I think for me that kind of highlighted the impact that all of us can make in this space if we recognize a condition, appropriately refer it, and get that person treated right through to the point where they're moving into adulthood, and it brought me back to what this is all about, which is the patient at the end of the day. And you have very eloquently summarized everything you need to know about growth hormone deficiency, differentiation, and diagnosis to help us treat our patients at the end of the day. So I want to thank you for your time today. I want to thank you for tackling so many questions in such a short space of time as well. And we're really grateful for you joining us. Thank you.
Oh, thank you for having me here. My pleasure. And I hope you find this talk helpful, for your practice.
We certainly will. If you are joining us from Metal, you'll be able to get the link in the chat box to the CME certificate. I'm going to pull up the QR code on the screen. So if you're joining us on another platform, you can also scan that QR code, and you will be able to claim a free CME certificate by completing that short evaluation. If this is the first time you've joined us here on Metal, I hope we'll see you again. We are deeply passionate about making medical education radically accessible, bringing it to you wherever you're at, so that it's easy to get involved, easy to learn, and always open access and free. So I hope that you'll be able to join us again next time. It's certainly been our honor to host you this time, and I hope you have a really great rest of your day. Thank you. Can't be too careful. Yeah, so they come from here, there, and everywhere, really. So we've got it out on Twitter, LinkedIn, Facebook, Metal. So yeah, so really good engagement, which is good. So and I know there's a couple that were very similar there. So sorry for giving you 2 genetic questions at the end, but trying to get through them all. Right. Here's the bottom line. But yeah, it was really good. It seems to have gone really well. Did you hear my voice twice at the start, James? Did you get that coming? I'm keeping an eye on Twitter, and everything else muted, so. He'll figure it out. Yeah, sorry.